The first speaker is Professor Marta Cohen. She is consultant pathologist and head of histopathology department in Sheffield Children's Hospital in United Kingdom. Professor Marta Cohen is pediatric and perinatal pathologist with many years of experience. Also, in 2020, she was awarded of OBE, Order of British Empire, by the last Queen Elizabeth for her role in investigation of SIDS. Also, he has an academic and she is a leader of pediatric and perinatal pathology, a specialist committee, and also, very recently, she is the vice president of the Royal College of Pathologists in United Kingdom. Thank you so much to coming here. Please, the stage is yours.
It's my first time in Romania, and I really love it. So I hope I come back again. So I'm going to present there are two papers, one published and the other not published. And it's about the placenta infection by SARS-CoV-2 and the physiopathology, and also how the histology and the outcome change between the Alpha and Delta variant and the Omicron variant. So the first is about SARS-CoV-2, what happened with COVID in pregnant women, about the placenta, what are we seeing in placental histology, and the fetus. So you can see that SARS-CoV-2 is a virus from Coronaviridae family, and these have two subfamilies, an RNA virus, and can be in mammals, or as well in birds, amphibians, etc. But in mammals, that humans are mammals. It has two subfamilies and 5 genera, 26 subgenera, and 46 species. And I'm going to concentrate in a beta coronavirus that give origin to the common coronavirus that has been here since 1960 and that caused a cold. SARS-CoV-2, that is what caused the pandemics in 2020, and MERS-CoV, that is also produced an epidemic. It didn't get to pandemics likely, but it's from the camels. So this was a paper that we published with the Medical Legal Institute, because I also do forensic pathology, pediatric, Medical Legal Institute in Spain, and we look at the postmortems on patients with COVID. But as I say, it was identified in 1960, and this is what already caused a cold. It's a zoonotic viruses, because this SARS-CoV-2 has 96.2% homology with a coronavirus from the bats, and this is the name of the virus in the bat. And it's 100 to 160 nanometers in diameter, with spicules that project in the like spikes and gives like a sun appearance. And this is very important, because all the physiopathology of SARS-CoV-2 is based on the receptors ACE2 that exist in many organs, in many cells, and how our immune system reacts. So I always think that in the future, this pandemic will be remembered as a pandemic that involved the ACE2 receptors and cause an immune dysregulation. And this is what we are learning now. So as I say, we don't know, because this is MERS, that is the one that in Saudi Arabia, and there are occasional cases of MERS, and it's very highly lethal compared with SARS-CoV-2 that is not so lethal. And we don't know, or the experts don't know, if it came from the bats to the civets, that is a mammal, that was an intermediate species that was also common in the Wuhan market when everything started in that area of Wuhan. They still don't know if Wuhan market was a consequence of if Wuhan market was where this mutation first originated. or it may be that it came from the civet and went through the bat. Possibly, it came from the bat to the civets. Why? Because the civets that were not in the area of Wuhan didn't have SARS-CoV-2. So that's why I think it's possibly the important thing. In May 2023, when we were already with high number of deaths, and it's wrong, it's before 2020, it was very clear that it was a vascular damage. And this is, forgive me, 2020. So the pneumonia that was causing SARS-CoV-2, people going to have this very difficult pneumonia and died of respiratory failure pneumonia was actually caused by the damage of the endothelial cells, and you can see thrombosis, microthrombosis. And this was published in this journal about vascular, we call it endotheliitis. It's an inflammation of the endotheliums because the endothelial cells are very rich in ACE2 receptors. Same that the placenta, where I'm going to expand soon. So the endotheliitis, you can see the virus in these endothelial cells with electron microscopy. At the beginning, we used a lot of electron microscopy because we couldn't identify the virus with immunohistochemistry. That now we can. We have the agent and we use it. And it was in the glomeruli, so it was causing renal failure. And you can see here, and at the beginning, this is Cas-Pas3 that is related with apoptotic, this antibody. And as I say, because this was an early paper, first describing the affection of the endothelial cells, it was not possible then still to do immunohistochemistry. So, as I mentioned, SARS-CoV-2 has these spikes, where is this protein that is used by the virus to go into the ACE2 receptors that are in the membrane, and then will cause the infection. And of course, there will be anti-spike antibodies. And these anti-spike antibodies that are our antibodies, or the antibodies created by the vaccine for those that are immunized, is that sometimes may cause an overstimulation and hyper-response. And actually, the patient become sick because of that. And what is important is this SARS-CoV-2 is in all the organs. So you can see that it's in different organs. You can see here that is in the brain and produce neurologic disorders, lot of Alzheimer and cognitive deficiencies caused by SARS for the COVID and the long COVID. Diabetes mellitus in the pancreas, a lot of increase of diabetes, type 2 diabetes, type 1 diabetes, because of its autoimmune. Hypertension, kidney disease, thrombosis. It's been an increase in the number of cases of thrombosis, thromboembolism, infarction, after, a long time after the patient had COVID, and sometimes younger patients. So, pregnancy. In 2020, it was said in March at the beginning. Remember, the pandemic was declared around the 11 of March. There was no vertical transmission. There was no risk. So this was the misconception. No? Or the virus, at that time, the serotype was L, was possibly likely not so dangerous for the pregnant woman and the baby. In Wuhan, there has been no case, but they start seeing an incidence of hypertension, preeclampsia, and on the 30th of April, the first pregnant woman that was positive gave birth to a miscarriage, 19 weeks gestation, and the placenta was infected, but not the fetus. In May 2020, the 5th of May, the University of Yale presented the case of a pregnant woman with pregnancy-related hypertension. She had coagulation problems. She developed disseminated intravascular coagulation, and the fetus was aborted. And this is something that we start seeing in pregnancy. Coagulation disorder, thromboembolism, and this will have an implication on the placenta. Again, the virus was in the placenta, and this time in the umbilical cord, but not in the baby. So, and where was in the placenta? It was in the trophoblast. And it was seen by electron microscopy and by immunohistochemistry. And again, in Yale, in May 2020, they described a very important immunologic component. And this is already what is shaping what happened later with the placentas and the babies. So then, we start seeing this in the news. Coronavirus attack placenta during pregnancy, shows a study. BBC, is the risk for COVID-19 higher during pregnancy? So these patterns start emerging. Black Asian minority women were 55% of the UK hospitalizations with COVID-19 among women. Then later, 20th of May, so I am showing you from March, April, 12, May, how much, how quickly progressed not only the infection, but also the understanding of the science about what was happening with COVID in pregnant women. So UCOS is the UK Obstetric Surveillance System, and they identify 427 pregnant women with COVID-19 between March and April 2020. The risk factors were maternal age more than 35. A pregnant woman more than 35 is an older mother. BMA, so is Black Asian minority. Obesity, comorbidities, diabetes, hypertension, asthma. The clinical symptoms were no more severe. At this time, and we are still talking about the L variant, there were few deaths. The admission incidence was 4.9 cases per 1,000 pregnant women. The mortality was not very high, 1 in 18,000. 5% of the babies were positive. So that means that vertical transmission by then was demonstrated. And this is 12 of these 427. 6 of these 12 were positive before the 12 hours after birth. That means that it was obviously congenital. But the majority of the babies were not infected, so 95% were not infected, and the babies usually were discharged soon after birth or had a minor complication. Again, 12th of May, they identified antibodies at 2 hours of life in a newborn in Wuhan. In Bergamo, Italy, later in 14th of May, the baby, 2 of 22 newborns whose mother was positive were infected. And then 16 pregnant women in Chicago in June, the placenta show features of preeclampsia and vascular insufficiency. And then they suggested vertical transmission may be possible. Now we know that vertical transmission was possible. Vertical transmission occur, and usually the babies, if they die because of the placenta inflammation and changes that I will show you, but not because there was any dysmorphology in the baby, there was no malformation in the baby didn't develop sepsis. If the baby died, usually was a stillborn or a miscarriage. So, where was, you can see here, electron microscopy. Where was the virus identified? In the trophoblast. So the trophoblast, are the villi, and this is, so whatever the villi is always fetal blood, and fetal component. This is the intervillous space, so this is maternal blood. And obviously, the virus came with the maternal blood and went into the villi, and this is the trophoblast, and this is exactly where the ACE2 receptors were. We now know that there are ACE2 receptors, and this is with electron microscopy, and this is using immunohistochemistry, and you can see, and this was the paper from the University of Yale in 2020. So this is immunohistochemistry positive for SARS-CoV-2. Obviously, we cannot say what sort of virus variant it is. It's generic. And where it is in the trophoblast. So again, for electron microscopy, you can see the virus invading the trophoblast here, and at higher magnification, you can see the virions. So this is when, at the beginning, we were looking into what happened with this virus, and then all these spikes that give like a sun, like a crown. So this is a virus membrane, and this is where the spines are, and this is the S protein, and the S protein is what joins the ACE2 receptors that are in the membranes of the cells. So, why is important? Because this is the renin-angiotensin system. So, it's important because it has to be with the physiopathology of this condition. Because this system is what it will imply that the renin, the protease renin, converts to angiotensinones, the angiotensinones to angiotensin 1, which is then converted into angiotensin 2. And this can bind to the receptors, angiotensin type 1, and can produce vasoconstriction, hypertrophy, fibrosis, proliferation, pro-inflammation, and oxidative stress. And therefore, if the receptor is used by the virus, this is what it will be tend to produce. Where, if not, it will be vasodilatation, vascular protection, etc., etc. That's why this disease, because SARS-CoV-2 is the virus, COVID-19 is a disease. So somebody may be affected and be asymptomatic. But if you have the disease, you have a high chance of high hypertension, thromboembolism, etc., because it has to do with the role of ACE2 receptors. So that's why it enters the lung, while the spike glycoprotein of the virus binds with the ACE2 on the cells and allowing the virus to enter. But at the same time, it will also, the infected cells will stimulate inflammatory cells and will go into the macrophages, and then this can, infected macrophages can also infect other cells in other organs in the body and can produce pro-inflammatory cytokines. So the role, we now know that the genetics of certain population made that you had asymptomatic infection, that you didn't get infected, or you had a very severe. It's all in the relation between your genes, how you react with your anti-inflammatory response. So it's always an excess of anti-inflammatory response. So that's why we had myocarditis. We had increase in rheumatoid symptoms, increase in diabetes, increase in neuroinflammation, etc., because it's all a combination between the two, the virus and the response. And this is what happened, and it may affect, as I say, any organ. So coming back to the placenta, because the placenta is an organ that is a fetomaternal organ. So it has a maternal component and a fetal component. But also, we start seeing that it become affected, infected and sick because of the disease. So it was demonstrated in 28 placentas without SARS-CoV-2 infection that actually they have ACE2 expression via immunohistochemistry. So they use immunohistochemistry against ACE2, and they demonstrated that yes, and where it is important, in the trophoblast. So everything started with the alpha variant. The alpha variant was first described around September 2020, and before the alpha, and it was first demonstrated in Kent, south of England, and from then caused a wave that was for a few months. And after the alpha variant came the delta variant, that I think was the most deadly one. And then at that time in the news, without saying it's the alpha variant, but we start seeing that was already public, stillbirth and prematurity risk may be higher in pregnancy. And by then we went already in October, November. So in 2021, we're still with the alpha variant and beginning of the delta variant. It was published that maternal and perinatal outcomes of pregnant women with SARS at the time of birth in England, and they did a study on 342,000 women, and 10%, 3,527 have SARS-CoV-2 infection, and was more common in women who were younger, non-white, that means black or Asian, primiparous, residing in the most deprived areas, or had comorbidities. I do a lot of vitamin D analysis because in other part of my interest is sudden infant death, and I always measure vitamin D. Vitamin D is an immune regulator, it's a hormone, it's not a vitamin, it's a hormone that makes the immune system stronger. So since the beginning I say, I'm sure there is vitamin D deficiency. And now we know that patients that have the most severe COVID and women with the most severe affected have vitamin D deficiency. And it's not a coincidence that are black, Asian, and in the most deprived areas, because that is also associated with vitamin D deficiency. So these women with SARS-CoV-2, by then alpha delta wave, significantly had higher rates of fetal death and preterm birth, significantly higher rates of preeclampsia, eclampsia, so hypertension during pregnancy, birth by emergency cesarean delivery, prolonged admission following birth, and the babies experience neonatal adverse outcomes, the need for special neonatal care, and prolonged neonatal admission following birth. So we are seeing a different picture that from we were seeing at the beginning. That's why I wanted to put the news in the newspapers. This was a systematic review about the vertical transmission. And they confirm that there was present in neonatal or fetal deaths of fetal sources and neonatal serology. The neonates of fetuses with severe acute respiratory syndrome were positive within 48 hours of birth. Of 30 eligible case reports describing 43 tested neonates and 38 cohort of case studies, they included all these cases in the study. And there was obviously by then a growing evidence that pregnant women could be at increased risk. And again, the risk factors were, by then, there was a vaccine. Remember, December 2020, I think the 3rd of December was the first vaccinated person. And it was then evident that women who were unvaccinated were at higher risk of COVID. And again, repeating, ethnic minorities, obesity, having comorbidities, diabetes, hypertension, being older of 35, living in increased socioeconomic deprivation, and facing, for instance, working in health system. No? However, as I say, no evidence of congenital anomalies, not like other congenital infection like Zika virus, toxoplasmosis, etc., that may cause abnormalities, not this one. Vertical transmission was uncommon, but it may occur, and vaccination in pregnancy was strongly by then recommended. In Latin America, I am originally from Argentina, so I was always looking at Latin America. It was very high, especially in Brazil, that is not quoted here, but it was present in all these, and it was related to a lack of intensive care treatment for these women. So the barrier of being deprived in a low middle income country in Latin America means for these women to have high mortality, maternal death. And the average maternal age in Latin America for affected women was 31 years, and 50% of those who died were obese. Usually more frequently detected in the third trimester of pregnancy. Women presented usually with dyspnea, with fever, cough, but in addition, organ failure was reported in 90.4% of the cases of those that were admitted, and they remained in critical care for a period of 8 days if they were admitted. And in most cases in women, death occurred during the postpartum period, 6 weeks after childbirth, So really, preterm delivery also became a perinatal complication, and almost 60% of the children were born with low weight. So this is important, because that means that really for a fetal-maternal medicine expert, for neonatologist and obstetrician, this was a serious event during, we are talking end of 2020 to end of, so the whole of 2021. So, important, during that time we were recommending the women to be vaccinated. 98% of the women that had COVID with symptoms during pregnancy, 98% had been unvaccinated. And only 3 of the 235 women admitted to intensive care had received a single dose of the vaccine, and none had received both doses. And all pregnant women then were recommended to have the vaccine. As I mentioned, Brazil has the highest rate of maternal mortality due to COVID, and this is worldwide. And there were, at December 2021, almost 2,000 deaths in Brazil, and 59% had not risk. Of course, the risk is living in a deprived country with deprived or low socioeconomic status for them, and also no access to intensive care systems. We did a study with, I think there were 8 centers in England, in which we look at the findings of the placenta, the stillbirth rate, the miscarriage rate. You know what the difference between stillbirth and miscarriage? Miscarriage is the intrauterine death below 24 weeks, and stillbirth is after 24 weeks. And we have a high percentage of placental infection with features that were very distinctive and had an immunologic cause. So that's why I was giving all this information about the physiopathology, the immune reaction, etc., and the autoimmune conditions that are involved in this. And this was during the alpha and delta wave, and how this was so, it was a calamity, really, because it was a very high percentage. And during Omicron, we did another study that we have not yet published. We presented in the International Stillbirth Alliance meeting that happened in June 2023, and we were thinking that, okay, we are not going to see any findings, any significant findings, because these women are vaccinated. And actually, what we found is that there are no significant findings, but the women were usually not vaccinated. So really, it goes to Omicron being less lethal than the alpha and delta. So we now are not in pandemics, and you know that you may have a cough, you know, a cold, feel unwell, tired, and actually you may test positive. And the recommendation now is you use a mask, but you don't need to isolate. You can, you know, use the mask and cover. And I think that in the future, SARS-CoV-2 is going to be like the flu, you know. People, you know, have to be vaccinated if you are more than 60, if you have a condition, or a health worker, and but you don't to isolate. If you feel okay and you have a bit of a cold, you don't have to test. So I think this is how it's going to go. So I'm going to go to our study. So before our study, in January 2021, there were 29 studies that reported the histopathological findings on 322 placentas. And then this is what is important, because many of the cases had increased fibrin deposition, and I will go into that, decidual vasculopathy, chorioamnionitis, intervillositis, deciduitis, etc. So there was a lot of fetal vascular malperfusion, but increased fibrin deposition was a big chunk of what it was found. And in inflammation, intervillositis and villitis were very common. and this is something that we also found. So, fetal vascular malperfusion, for those that are not pathologists, I mentioned that there is a fetal component and a maternal component in the placenta. So the villi are completely avascular because it has been a thrombosis. And we call that fetal vascular malperfusion. And it's something that is not specific of COVID, actually, but we were seeing that in COVID. The inflammation, again, inflammation in the villi, and most inflammation in the intervillous space is called chronic lymphocytic intervillusitis and chronic deciduitis and chronic villitis. These were all conditions that usually chronic villitis doesn't coexist with the intervillusitis, but we were seeing the two things together. And there were things that were existing, and they have a recurrent risk because they have an immune origin in the mother. And what is massive peribilious fibrin deposition? That is the other excess of fibrin that it was very common. It's a rare placental pathology, less than 0.5% of the cases. However, we were seeing a lot of these during COVID, placentitis. It's extensive fibrous deposition, more than 30% of the volume of the placenta. It's associated with growth restriction and stillbirth. In this case, we did see associated with stillbirth, but usually not with growth restriction. Why? Because it was very acute, the development, while the immune condition that existed before, that is very rare, is usually long-standing. And we saw this associated with chronic histiocytic intervillusitis, that again is a very rare condition outside of COVID. So by then, in 2021, we were already, this paper is from May 2021, 6 live births, 5 stillborn, all had a COVID positive. So you can see almost 50% were stillborn, and all had chronic histiocytic intervillusitis and trophoblast necrosis. And this is an immunostain to show that the virus was present in the trophoblast. So, at Sheffield Children's Hospital, from November 2020, remember that soon after the alpha wave started, we start seeing an increasing incidence of what we call placentitis. That is the association of massive peribilious fibrin deposition, chronic histiocytic intervillusitis, and trophoblast necrosis. 3 conditions that usually they don't associate together, but we were seeing this associated to stillbirth and no intrauterine growth restriction. And you can see here the fibrin, the trophoblast necrosis, and the intervillusitis. So this was a 33 weeks baby, a placenta, cesarean prematurity, lobe Apgar. The placenta was not small, adequate weight, normal fetal-placental ratio, means the baby didn't have intrauterine growth restriction, and had a marble appearance that involved 25% of the parenchyma. And you can see how there is no maternal intervillous space. It's all occupied by this fibrinous material, and that is massive peribilious fibrin deposition. I always say it's encasing the villi, so there is no intervillous space. And we did, at the beginning we were doing electron microscopy, then we were doing PCR from the placenta, but then we got the antibody and it was positive with SARS-CoV-2. But in this case, we also did, you could see the virus in the trophoblast. It was in the intervillous space, and it's all the virus. Another case, 34 weeks, cesarean antepartum hemorrhage. Again, the placenta adequate weight. Again, no intrauterine growth restriction. And the maternal surface was, the cut surface was firm and pale. And another case of chronic massive peribilious fibrin deposition. And you can see here, this is the sludge is the trophoblast necrosis. And was very, very positive. Everything brown is the virus. So this was maternal peribilious fibrin deposition, chronic histiocytic intervillusitis, SARS-CoV-2 placentitis. And this is the study that we did and was published in one of the Lancet, in which we were a few centers from England that participated. So this was the collective experience, and we tried to characterize the cohort of the placenta during the alpha and delta waves. We had 59 cases from 8 institutions. Babies were within the placentas 19 to 41 weeks. 61 babies delivered because they were twins. All had massive peribilious fibrin deposition with or without intervillositis, with a positivity of SARS-CoV-2 in the placenta, and 81% were third trimester, more than 28 weeks, and 49% had an intrauterine fetal death. And the majority were obese and women with Black Asian ethnic minorities. We don't see this anymore, as I'm saying. I'm sure this is the same here. So we saw vertical transmission because 6 infants, 4 live births and 2 stillbirths tested positive, the babies, by PCR. 5 infants tested negative following delivery, and we don't know the status of the rest. So what was the maternal status? 79% of the women had PCR positive at the time of the labor or in the months before. 3.4% tested negative at the time of delivery and didn't know that they had SARS-CoV-2. We made a diagnosis with the placenta, and almost 17% maternal status was not known to the clinicians or it was unavailable. 12.5% of the women were asymptomatic, and 46, almost 50% reported symptoms like pyrexia, breathlessness or dyspnea, cough, headaches, and 6.3% had severe illness and they required intensive care admission. And almost a third, we didn't know the symptoms because we were based in the request form. So if there are clinicians, obstetricians, please always provide information to the pathologists because we need that information. So the timing, we could calculate in 22 of the cases. 5 mothers were positive on the day of delivery, 4 tested positive less than a week before delivery, 6 were positive between 7 to 14 days prior to delivery. But remember, if the mother in this case is sick, doesn't mean that she will become negative in a few days, in 5 days, 6 days. As they say, on 6 days you're negative. No, the virus, a person that is with the virus replicate, it is always positive while it is in a serious condition. And 7 cases were positive more than 2 weeks prior to delivery, including one who tested positive 4 months before delivery, but may have had COVID more than once. So, again, fibrin deposition was usually more than 75% in 32 cases and was less than 25% in 8 and in the intermediate in 19. And was always is very marble in appearance, very pale, and you cannot identify the intervillous space. And this is again with intervillositis, that is lymphocytic and histiocytic inflammation, and outside COVID is an autoimmune cause. So my question now, and set up, I think I discussed this with you, what is going to happen with these women after? Because we know that massive peribilious fibrin deposition and chronic histiocytic intervillositis have a recurrence risk for the next pregnancy. So could it be possible that SARS-CoV-2 trigger an autoimmune process that then continue in the next pregnancy because it's already, woke up the immune system? So we don't know. Time will tell. Trophoblast necrosis is this smudging of the nuclei and the karyorectic debris. And of course, electron microscopy, we don't do anymore, but we did. So the proposed mechanism of placental infection relies on the presence of ACE2 receptors on the syncytial trophoblast, and with viral endocytosis supported by a host of the transmembrane serine protease. And infections then trigger both a direct and indirect immunological response with the release of inflammatory cytokines, as we saw. It happened in other organs, why not in the placenta? And why massive peribilious fibrin deposition? It may be possible that the synergistic effect of the immunologic dysregulation induced by the virus and an underlying or acquired thrombophilia in the mother. So I think this is related with the thrombophilia because we know that SARS-CoV-2 induced thromboembolia, and thrombophilias in these patients. Or either the fetus triggers the trophoblast necrosis. We don't know. Okay. So I'm going to say it's important for the pathology trainees and those pathologists that don't do placenta to see the difference between massive peribilious fibrin deposition, chronic histiocytic, and COVID placentitis. So massive peribilious is rare. It has intrauterine growth restriction, low placental weights, and high fetal-placental ratio because of the small placenta and intrauterine growth. Stillbirth rate is high. Is more common in the third trimester. Variable recurrence rates between 12 to 78%. No SARS-CoV-2 related. Variable necrosis in the syncytial trophoblast. And to be honest, it's not a feature. Chronic histiocytic intervillositis is rare. So there are two different entities that in SARS-CoV-2 we saw them associated. Also produce intrauterine growth restriction, also had pregnancy loss, is in the first trimester, in difference with this, high recurrence rate up to 100%, and absence of SARS-CoV-2 immunostain, variable necrosis, and the other is an unknown incidence. I think now we can say it was high with the alpha and delta, but now it's not high. As I will show you, normal fetal weight and placental weights, 49% of intrauterine death. So the intrauterine death is always high, either if it is with COVID or without. A non-recurrence, we don't know. More common in the third trimester. Obviously, SARS is in the syncytial trophoblast, and extensive necrosis of the syncytial trophoblast. So, important, mothers could have been completely asymptomatic, and 75% of stillbirths were with asymptomatic mothers, or they may be symptomatics. And so we then, whenever I see now massive peribilious fibrin deposition, and I see a chronic histiocytic, associated or not, I will do SARS-CoV-2. And we still see them. I only saw recently one case. It was Omicron. It was a fully vaccinated mom, had a miscarriage with this. So these features were present, and I did a SARS, and it was positive, and then I found out that mother has been fully vaccinated. So obviously she has some genes that didn't protect her. So was associated with double risk of stillbirth during the alpha and the delta wave. And so what happened during Omicron in women that were not vaccinated or partially vaccinated? And as I say, we know that vaccination in SARS-CoV-2 proved to be effective during alpha and delta wave. And so what we did was looking for the features of placentitis during this later wave. And we compare the status against the maternal vaccination status and the histological findings, and we compare with the previous wave. So we did a retrospective review of the specimen during October 2022 to January this year that was already Omicron. So we look for the maternal demographic, the pregnancy outcome, and the placental findings, and we did the comparison with the statistical analysis. So what we found is 189 placentas were included that were from mothers that were with COVID, that we presume it was Omicron, because obviously we didn't do the analysis of what variant. 38 were the average age of gestation, and 75% were white British or white European. So you can see that is already a difference in the demographic of these cases. Vaccination status. So completely vaccinated, a third, partially vaccinated, 12%, but most of the women, 55%, were not vaccinated. And this is what we found. We didn't find three things: a massive peribilious fibrin, chronic histiocytic intervillositis, and trophoblast necrosis. We find all of this. So histological chorioamnionitis, distal villus maldevelopment, bilitis, etc. I'm not going to read this, but it's important that most of the cases had chorioamnionitis, that is an infection in the amniotic fluid and the membranes, distal villus maldevelopment, that is something that we do see associated with gestational diabetes, and that was very common, and bilitis of unknown etiology. So this is what we see. So it's completely different. We didn't see the placentitis, and this is the intervillositis, massive perivillium deposition. It was only between the two of them, maybe 7%. So completely different. So this is delayed bilious maduration, as in gestational diabetes. We do see a lot of fetal-maternal hemorrhage, that is intervillous thrombosis, chronic deciduitis, that is also autoimmune, and bilitis of unknown etiology, that is also autoimmune. We did see, but it was always low grade. It was not associated to stillbirth. It was not associated to miscarriage. We did see fetal vascular malperfusion related to thrombosis, thromboembolism in the chorionic vessels or in the umbilical cord. And you can see these villi that are completely avascular compared with the others that are normal. We did see a few cases of peribilious fibrin deposition, chronic histiocytic intervillositis. So, but the reality is that there was no statistical significant difference in the placental weight, in the gestational age at delivery, proportion of preterm birth, ethnicity, or fetal-placental weight ratio between the groups of vaccinated, partially vaccinated, and unvaccinated. And there was also no difference in the statistical findings. And another large national study that was in England showed a significant reduction in the hospitalization risk of the pregnant women during the Omicron dominant period compared with the previous, the Delta, that I think it was the most lethal, or most serious, the Delta. Stock in 2022 conducted a population-based study in Scotland, showing also that during the Omicron dominant period, pregnant women were less likely to have a preterm birth or maternal critical care admission. So our findings, I really was expecting to say vaccination is a must because it is protective. Reality, no difference. And this was also seen after adjustment for maternal age, deprivation, ethnicity, etc. So these clinical findings from England and Scotland are parallel to our findings. So obviously our limitations, single center study, Sheffield, and the SARS-CoV-2 variants were qualified based on the population prevalence of Omicron, but we didn't do an analysis of every cases, and these are the references. Thank you.
Congratulations, Professor Cohen, and thank you very much for this very interesting lecture. I'm a neurologist, and in April 2020, the former president of the Romanian Society of Neurology, that in fact he died of COVID in September, unfortunately, asked me to make a presentation regarding coronaviruses and the central nervous system. And in fact, I found articles that since 1981 was one of the oldest mentioned that maybe coronaviruses might influence or might be the onset of degenerative diseases like Parkinson's disease, then Alzheimer's disease, and so forth, so on. But in fact, I find a very different presentation and a different clinical aspects and imaging aspects from what we know today. There are COVID complications of the central nervous system and what I found in literature previously regarding coronaviruses in general. And this is what I wanted to ask you regarding placenta and this placentitis that you presented, and you are well known for your involvement in this research. Did you find previously to COVID such placenta, and the question if there might be a coronavirus involved?
Coronavirus was well known to us, but as I say, as a cold. SARS-CoV-2 didn't exist before then, possibly started in November 2019 in the area of Wuhan. I think it's maybe a laboratory accident or a natural evolution of the virus. I have not seen a setup here from Turkey. She's also an experimented pathologist in placenta. I have seen bilitis, but bilitis cause for torch, so toxoplasmosis, herpes, cytomegalovirus, but it's completely different, and you see the viral inclusions. So I think that what SARS-CoV-2 caused this immune dysregulation, that caused these immune conditions, massive peribilious viral deposition and chronic histiocytic, have not seen, and also associated, the two together. But it's very interesting what is happening with, especially with long COVID in the brain, because it affected so much the neurocognition and the Alzheimer. I know people who had COVID and soon after started the deterioration and went into having an Alzheimer. So I'm sure that this pandemic has a lot of bad things, but also brought us some light for us to learn about the physiopathology of many diseases like Alzheimer that have an autoimmune component. So maybe that triggered by a virus, yes, because a virus may trigger that. So, but I don't have more answers than that.
Thank you very much for the talk. It was very interesting. You mentioned in the early part of the presentation that macrophages are carriers for the virus through other parts of the organs, other parts of the body. I was wondering if you know anything about specific mechanisms of the SARS-CoV-2 virus that evade the macrophage antiviral properties.
That's not my area of work, but what I know is that SARS-CoV-2 triggers inflammatory mechanisms, and that's why attract macrophages, lymphocytes, etc., to where the virus is. And what that paper mentioned is that it can be the virus enter the macrophages and the cells, and then they are transported through the blood into the rest of the body and may affect other organs. Of course, one is in the blood, and it's affecting mainly the endothelium, and then it can be anywhere in the body. Thank you very much.